Hello, everyone, and welcome to our Ask the Doctor session tonight. My name is Shelly Korean with SkyPass Foundation, and I hope all of you had a safe and happy and healthy holiday season and a happy new year to all of you. We are excited to kick off our first webinar of 2021 on the topic of the do's and don'ts of Parkinson's disease. We actually did part one in the series back in December. And for those of you who missed that, I will post the link in the chat box if you're joining us live on Zoom, so you can go ahead and catch that at your convenience. Presenting tonight is Dr. Shilpa Chitnis, one of my favorite people to work with, perhaps one of your favorite speakers to listen to. Dr. Chitnis is a professor of neurology and a movement disorder specialist at UT Southwestern, and she works very closely with us here at SkyPass Foundation in our mission to serve the Parkinson's community. So Dr. Chitnis, thank you so much for being here tonight. And with that, let's go ahead and jump right in. Dr. Chitnis, you should be able to share your screen and we can go ahead and get started.
Hi, everybody, and wish everyone a very happy new year. Hope to have a really great lineup of speakers for this year. Shelly and I are working on getting, now that we have the Zoom platform, I think we should be able to get some really nice international speakers from Australia and also from Asia as well as from Europe. So without any delay, so I was going to jump into this slide, which I rushed through last time. And the reason I want to show this slide as we are going into talking about non-motor symptoms, etc., is that, you may have heard of the Hone and Yahr staging for motor function in Parkinson's disease. And essentially, if somebody develops their first symptom, which could be either tremor or bradykinesia, and that's considered to be stage 1 of Hone and Yahr. But technically, behind the scenes, I think we know, there is now a pre-symptomatic, preclinical stage of Parkinson's disease that could potentially be starting, 20 years before the onset of the first symptom. And so what this picture really shows is this pathological hallmark of Parkinson's disease, which is Lewy body. And Lewy body actually, may start either here, which is the olfactory bulb. The olfactory epithelium has dopaminergic neurons, as well as, this is coming from the vagus nerve that's in the gut all the way climbing through the brain stem. So essentially, if you look at this particular structure here, which is called the midbrain, where we have the substantia nigra, where the neurons which contain dopamine exist, and they go from the nigra to the part of the brain that's called striatum, and where dopamine is released. So it's important to recognize that what is considered to be the stage 1 of Hone and Yahr is actually almost stage 3 or beyond of Braak staging. And Braak staging was purely a pathological staging, which was based on the presence of Lewy bodies in different parts of the brain. So it's very important to understand that this disease may start so many years, decades before the onset of the first cardinal symptom. And obviously at this point, we don't have a pre-marker or a biomarker that could basically tell us, who will develop Parkinson's disease. At the same time, we don't know, who all would be considered to be a highly susceptible population that we would start testing if, we had a particular test. Let's say I wanted to know what's my risk for Parkinson's disease. Am I starting now? Can I go get a DAT scan? I mean, sure I can, but, what then? Like, do I treat myself with dopamine? I'm not symptomatic, right? So you could bone up on exercise and wait for, Michael J. Fox Foundation or whoever else that's, has the fastest race to getting to a neuroprotective agent. So really important to understand, this concept. And I'm going to fast forward through some of these things that I already, talked about, and essentially talked about non-motor symptoms that exist. And then for those of you who are not here on part 1, I just want you to understand that I'm not putting in the pitch, for movement disorder neurologists to get more referrals, because, my wait time is about 6 months. But it's important that somebody that is really trained in movement disorders and spends 1 to 2 years of their life seeing only movement disorders, is a good person for you to see. Even if you don't live nearby, if you are 2 hours, 5 hours away from a movement disorder specialist, to see them at least once a year, and they can work with your, I'm happy to work with anybody that's even a general neurologist in the community or somewhere, just to help the patients get, the best care. And I had just shown some websites where you can just go and plug in. And what I'll do is I'll share a PDF of this entire presentation with Shelly, and she will subsequently, mail it to you guys. And these are just some prominent and not so prominent movement disorder neurologists. Um, don't know whether I talked about this, but I'll quickly run through this. Is when you go for a visit, let me tell you what is one of my biggest challenges as a Parkinson's doctor. When I see a patient for the first time and they come by themselves, it is very challenging, because it is very hard to tell a patient by themselves without having any family support, that I'm sorry, I think, because sometimes they come to me and they have been diagnosed with essential tremor, and then I have to undiagnose them and tell them that actually, or I have to say you have essential tremor, but these are findings that suggest I'm very suspicious that this could be the beginning of Parkinson's disease. And I hate, absolutely hate to give this diagnosis alone to a patient. So I always recommend for people to just bring, a spouse or a friend or a kid or somebody that you're very close to, that can be, a source of support. I've been taking care of patients with Parkinson's disease for 20 years, but the thing is that the person that's just diagnosed like today for the first time, imagines their whole life in front of them and thinks about the impact of a, what we call a neurodegenerative disorder, on their lifespan, and also on their dreams and aspirations that they plan for themselves. So always, try to bring somebody with you so that you have some support. And then we talked about, coming with a lot of questions. That's really important. I'll tell you very honestly, the visit times for seeing patients is getting shorter and shorter as the reimbursement paradigms change. Thankfully, being in academics, I have 30 minutes for a follow-up patient. I can spend a lot of time. But even for me, if people write down their questions, people bring their medication bottles. Unless you have a list of your medicines, it really makes it a great visit, not just for me, but it actually makes it a great visit, for you guys. And here are some legitimate websites that I talked about. Somebody had asked me, I think that locally, the Parkinson's Voice Project is a really good resource. I think they have, Samantha and team have done a really good job of bringing national and international speakers. We have lots and lots of videos that they have. I'm on a couple of those videos that they've posted. So I just need to make that change and add, just for highlight a local organization. That's the Parkinson's Voice Project, is really helping patients lead, better lives. Um, so I was just making a joke of it, that if you have any questions, some of these may be misperceptions. Just write those questions and ask your doctor, because the doctor can certainly tell you, what is right and what is not so right, on what's wrong. So I talked a little bit about, diagnostic tests for diagnosing Parkinson's disease. I cannot tell you how many times a patient says to me, I went, I saw my primary care doctor. They were very suspicious that I may have Parkinson's disease. They sent me to a neurologist. They got a brain MRI. They looked at the brain MRI and they said, you have Parkinson's disease. And, not to make light of it, but I tell them, I said, I've been a Parkinson's doctor for 20 years and I still have not been able to diagnose Parkinson's reading a brain MRI. So I really need to learn what it is that your general neurologist found. And really, imaging is going to get very, very good. We are making so much progress. Technology is making so much progress. Imaging at some point is going to show certain things that could make us look at those findings and say suspicious for Parkinson's. We're not there yet. So really, even in 2021, I'm so glad 2020 is over, that the diagnosis of Parkinson's disease is made on the basis of history and physical exam done by a astute movement disorder specialist that can spend a lot of time. Why do we order brain MRIs? We order brain MRIs, sometimes, to look at, rule out different things. And the things that we're looking at is, this is a brain tumor called glioblastoma multiforme, but it is encroaching upon, the striatum, and this can basically give symptoms that look like Parkinson's disease. The other things that we look for is normal pressure hydrocephalus. We look for people who have diabetes, hypertension, high cholesterol that develop these changes. We call them white matter changes, and this is vascular Parkinsonism. And then, of course, brain MRI can definitely tell us some subtle findings that would be suggestive of atypical Parkinsonism. And last but not the least, we're talking about we're talking about getting a DAT scan, which really is just supportive to the clinical diagnostic considerations. So moving along, um, we talked about medications, and it's so important to know your medicines. And I remember when I was a fellow, and the patient would say, I take a blue pill, and I take a pink pill, and I take a yellow pill. And I literally made it my business to know all the Parkinson's medicines and their colors. And so for the most part, at this point, 20 years down the line, actually somebody told me a blue pill and a yellow pill and a pink pill, I might be able to tell you, or a capsule, I might be able to tell you what those medicines are. That notwithstanding, make a detailed medication list, separate your PD medicines from the non-PD medicines. Um, it's not a bad idea to know generic and brand name for your medicines, because, sometimes somebody will say, well, levodopa, carbidopa, and I'll basically say Cinemet. And so if I ask somebody, are you taking Cinemet? And they say no. And I said, you had Parkinson's disease for 10 years and you're not taking Cinemet. I got to know what it is that you're doing. And they say, but I take levodopa, carbidopa. So, it's important to kind of know that, and really important to know the exact strength of the medication. Just write it down, make a list. For older people, have your friends and family make that list for you. And then, Parkinson's doctors are very, very fastidious about um, how many tablets do you take at what time. So what do you take at 7? What's your next dose? If it's 10, what do you take? And if at all any side effects that you're having. It's really important, because the reason for this, most importantly, is if you tell me I take one tablet, um, and I take it every 6 hours, take it 4 times a day, then my question is one tablet enough for you? Like, does that one tablet give you at least 60 to 70% control of your Parkinson's symptoms? And if you say no, then that gives me an opportunity to go up on the dose of the medicine. If you say I take my medicine every 6 hours consistently, and I ask you, does your medicine last 6 hours? Meaning that, are you asymptomatic or relatively minimally symptomatic until the time that you are ready to take your next dose? And if your answer is no, at 5 hours I start to shake and I shuffle and I cannot walk anymore, then I know that I have to move your medications either closer together, or I have to change you, to an extended release form of Cinemet, such as Rytary, or I can add some adjunct medications that can give you more on time. So these things are really important for a doctor to basically know. And then I know we talked about, and I'll skip this because we talked about, uh, and if there's time, I can come back and do it for the people that were not here on the thing. And this just talks about how you have to take your Cinemet on an empty stomach with a full glass of water, and try to wait an hour before eating anything, and to avoid interaction between food and protein. But remember, I mean, um, patients have to be able to tolerate the medicine. If my patient won't tolerate the medicine, they won't take it, they won't get better, right? So it's not, I would, if you can, then this is the manner in which I would like for you to take the medication. But some people say, I just cannot take it on an empty stomach. I have nausea, or my tummy doesn't feel good. Then tell me, because then that gives me an opportunity to say, should I give you a medicine called Tigan, which helps with nausea? Or maybe you can take some crackers, or you can take it with applesauce, but don't take it with anything that is protein, such as milk or yogurt, or fish or chicken or things like that. So it's really important to be able to tell your doctor exactly what your problems are, so that we can fix it. All right, so this is the new part. So going to know your medicines. So we talked about gold standard, which is levodopa, carbidopa, or Cinemet. And so the next category of medicines are called dopamine agonists. Agonists are medications that basically just they mimic the actions of levodopa. They are structurally very different. They act on the same receptors such that levodopa acts on. There is only one medicine that is equivalent in efficacy to levodopa. And I'm going to ask this question to the audience. If somebody can raise their hand, and maybe Shelly can unmute you. Can you name one medicine that is almost equivalent in its efficacy to levodopa?
Alternatively, you can put it in the chat box as well if you don't want
Yeah,
to.
you can put it in the chat box. And I was, if anybody can tell me um, which medicine is almost equivalent to efficacy to levodopa. I'm not sure anybody's. Can they raise their hand, Shelly? Would that be, I'm just curious to find out if people know uh, which medicine is very close to.
Let's see. It looks like Sharon Roberts has raised her hand. Let me see if I can allow her to talk. And Carla says Ropinirole in the chat box. Let me see if I can unmute Sharon.
Sorry, Carla. I'm not seeing chat box like you're seeing it. I don't know if I'm missing something. I only see one. Um, are you seeing a different chat box, Shelly?
We should be seeing the same one.
I'm not seeing the whole chat box.
Sharon, are you able to speak
Yes,
now?
I am. I think it's pramipexole, Mirapex, but I'm not absolutely sure.
Okay, so the answer is not Mirapex, and the answer is not. Okay, now I'm seeing the chat box. I was looking at
Reclip.
Q&As. Go ahead.
Never mind.
Um, yeah, so actually the answer is apomorphine. Apokin or apomorphine is the medicine that is almost equivalent to levodopa in efficacy. If anybody has taken apokin, there is now, and I would say maybe, more the subcutaneous injectable apomorphine, because it kicks in about 10 minutes. It's a short acting medicine, but anybody that has taken apokin will just see very quickly within 10 minutes, you turn on. So that is basically the medicine. The I think the sublingual film is has, I don't know whether it has ever been compared, but may not be as as good as the it's still very efficacious, but not as good as the injectable apomorphine in terms of efficacy. So the dopamine agonists are basically pramipexole, Mirapex, um, ropinirole, which is Requip, rotigotine, which is Neupro patch, and apomorphine is also a dopamine agonist. It's just a short-acting dopamine agonist, and these are newer dopamine agonists. In the past, some older people may have heard of medicine called bromocriptine. The structure of these medicines has something, we call it the ergotamine, ergot structure. That particular structure made people have fibrosis of their pleura, of their pericardium, of their peritoneum, of the cardiac valves. And there was a medicine called Permax or Pergolide, which was banned by the FDA because it caused basically cardiac valvular fibrosis, and because of the ergotamine structure. And we don't use bromocriptine anymore. Um, and so these medicines came about in about the late 1990s. I was a resident at that time. At that time, the concept was that let us focus more on levodopa sparing therapies, because there is this concern that if you take levodopa too early, then it is going to prime you to develop pink dyskinesia. And so therefore even us, the movement disorder specialist, tried to use monoamine oxidase B inhibitors such as salicylic, or really more so rasagiline, or we tried to use dopamine agonists. And it's interesting that my colleagues and I, where I worked in Louisiana, used to have a race to what is the longest that you can keep a person away from levodopa, because we were using levodopa sparing therapies. But lots and lots of research and knowledge about the side effects of the dopamine agonist has now brought us to a point where most movement disorder neurologists do not use dopamine agonists at all. Not that they just don't use it in people that are more than 65 or having cognitive issues, but I honestly almost do not use a dopamine agonist. I've used rotigotine at times to help people with restless leg syndrome. Uh, Sometimes people come to me that are already on the dopamine agonist, and I usually try to just kind of reduce the dose and eventually try to take them. Why? But there has to be an explanation, right? So here are a couple of problems with dopamine agonists. Um, Sleep attacks. A person that tries to fall asleep goes through many stages of sleep before they go into deep sleep. These medicines, literally without a warning, you're driving on, Dallas North Tollway, and bang, you fall asleep. I'll tell you a funny story, which is going to, everybody's gonna laugh at me for my lifetime. Is when New Pro patch came, one of the reps had left some placebo patches, on the counter, and but in addition had also left some real patches on the counter. And Dr. Chitnis, being as absent-minded as she is, just comes, wants to take a look at. I want to try out, what a patch looks like, and does the patient truly get irritation, and how bad it is. And so I just absent-mindedly pick up a patch, I put it on, I forget about it, and then I'm in my car and I'm driving, and then something starts to itch. So here I am aggressively scratching myself, and 5 minutes later I'm super nauseous. I have to stop the car. I throw up two times on Dallas North Tollway, get into the car feeling really bad, and bang, I fall asleep at the wheel. And then I get off on the side, turn my red lights on, and then call my husband to come and get me. Unfortunately, I had taken a 6 milligram patch of Nupro and put it on myself instead of the placebo patch. And as I was scratching, I ended up giving myself a vapor dose of Nupro, and that resulted in sleep attack, that resulted in intense nausea and vomiting. So this is very difficult, especially if you're a young person and you're working and you have sleep attacks. Is very dangerous. Um, the other really important thing to understand is basically, the risk of impulse control disorders with dopamine agonists. It is around 2003. I remember that, I was pregnant with my child, and the first reports came out. Mark Stacey at Duke University published a 2003 neurology paper where they talked about a number of patients that basically developed these impulse control disorders while on dopamine agonist. These medicines are called, marriage breakers. Absolutely great, committed men started having affairs, started going, 80-year-old men engaging in pornography, people meeting just random people outside, cheating on their spouses, people losing hundreds of thousands of dollars. I mean, this is a serious problem. And let me tell you something that is really important. It is not just that you develop an impulse control disorder. Once you develop an impulse control disorder, it is very difficult. It's almost like being on cocaine, and then it's very hard to come off it. And people also develop something that is called DAWS, dog alpha war Shilpa, which is dopamine agonist withdrawal syndrome. And that's really, really difficult. And, and the reason for this is because these dopamine agonists stimulate certain receptors in the brain, which we call the limbic system, which is the reward and reinforcement center in the brain, and that causes people to do these things. And unfortunately, so many marriages broke up because of that. I was very happy to hear that there were a couple of people that basically were able to figure out, what the problem was once this data came out, and were able to hook up and get back together. But it's very traumatic for everybody to go through this, and this is dopamine agonist withdrawal syndrome. Sorry. Okay. So the other medicines, I'm just kind of, uh, the other medicines that we use for monotherapy as a single agent are monoamine oxidase inhibitors, such as, Azilect or Rosagiline. Selagiline is an older MAOB inhibitor. Some patients come to me on it, and I don't always try to take them off it, but if I had to use, I'd rather use Azilect. Selagiline has more side effects, more interactions with things such as antidepressants. Um, and the question of whether, I could spend a whole evening talking about is Rosagiline or Azilect neuroprotective. I think that the jury is out on that. They did some very good initial studies, to try to study that. I think that the study design, the way it was, the you know somehow the FDA looked at the data and did not give it a stamp of approval for neuroprotection. Having said that, rosagolin is a weak um, dopaminergic agent that can certainly be used in early therapy in patients who have very mild symptoms. So let's say somebody comes to me, they have very mild symptoms, like my handwriting is not that good, or maybe I just every so often my pinky will do a little bit of twitch. It doesn't really bother me, and generally the paradigm is to um, treat rather than not treat. And although I will say that some movement disorder neurologists still prefer not to treat, but I know that there is one paper that came out that looked at people that was started treatment early in the course of the disease, had I'll have to pull up that paper, had somewhat longer survival compared to people that were not treated at all. This is not carved in stone, but some people don't like to start medication early. If you can afford Azilect and you don't have any side effects or drug interactions, for mild patients, I may just put somebody on Azilect. In the past, we used to put them on dopamine agonists, but we don't do that anymore. But obviously, somebody that has more symptoms, I'm not hesitant at all to start them on levodopa, carbidopa, or cinemet or Rytary as a first agent. And the reason for that is that the quality of life significantly improves in a patient once they are started on the real deal. I think we can manage the titration of levodopa, carbidopa very slowly and very well, only as needed, so as to be able to not eliminate, but at least try to reduce the incidence of dyskinesias. Although data shows that at 5 years, 50% of the patients are likely to develop at least some form of motor fluctuations, and at 10 years, 75% of patients can develop some sort of motor fluctuations. This is the nature of the beast with dopaminergic treatment. I think that I in my clinic I hardly have anybody that has painful or disabling dyskinesias. So I think that I'm perfectly okay with starting levodopa, carbidopa even in younger patients. Of course, we know that younger patients are more susceptible to developing dyskinesias, but as we know that deep brain stimulation has now been approved once you've been symptomatic for 4 years, and your Parkinson's doctor deems that this is not atypical Parkinsonism, this looks like it is going in the direction of idiopathic Parkinson's disease, and you have dyskinesias or motor fluctuations, or a tremor predominant disease that does not respond to 1000 to 1200 milligrams of levodopa, carbidopa, then I have no problem starting to talk to them about early DBS. And that would be a session by itself, and we'll try to get somebody to talk about early DBS in one of the sessions during this year. So I want to focus on some other important things. Number one, you don't take care of Parkinson's disease in a silo. I highly encourage for even newly diagnosed people to join some kind of a support group. I think people are very reluctant to join support groups, obviously because they don't want people to know about the diagnosis. At the same time, they see patients in various stages of the disease in the support group and are worried about what they will look like. Again, it's an individual preference. I personally have found support groups to be very useful, and once people participate, I consider the Parkinson's Voice Project to be some sort of a support group. What we are doing here is some sort of a support group where people get together, talk about the disease, learn things, support each other, and are able to help each other. I think we are very fortunate that Dallas Fort Worth area not only has a very excellent resources from a physicians and treatment standpoint, but I have to say the plug for all my patients is that I have the best patient population as far as the Parkinson's patients go. So we have to take best care of them, and so you have to build a multidisciplinary team. So obviously, you are really at the center of the universe. Like Dr. Mike Oken says, the patient is the sun, and then we all kind of revolve around the patient. And so we, as me, that's the neurologist, depending on what the patient's needs are at different stages in the disease, you may require obviously pharmacist at all times, a speech and language pathologist such as Samantha Ellendery and others, You can have physical therapy. Stacey Sheeran, Mike Braish, they do PT. Sometimes occupational therapy, to help with like fine motor things, some skill sets, uh, and then clearly other things. So some people may basically require a dietitian. Some people may see a geriatrician for DBS, or focused ultrasound. You can see a neurosurgeon, caregiver. A lot of the patients, especially the young onset, don't like to use the word caregiver, and I totally understand that, or a care partner. Um, and I really, try to pay attention to what the patient, likes to hear and what terminologies. And if somebody ever tells me I don't like caregiver, I never use it in front of them. Um, Sleep specialist, I think it's really important. I'll get a phone call, Dr. Chitnis, it's like 4:59 on a Friday. I need you to give me something to sleep because I have not been able to sleep for the last month. And I'm like, why are you calling me at 4:59 on a Friday when you have not been able to sleep for a month? I need to talk to you, get a history. One person sent me an email on a Saturday saying that they couldn't sleep and they wanted a pill. And I literally talked with them, try to get a really good history, try to figure out, what are some of the barriers, and what are some of the mistakes that they were making. And I was able to give them enough tips. And I got literally an email from them on Monday or Tuesday saying, wow, you gave me some really good tips. I was able to sleep. I was doing so many things wrong. But of course, people have Parkinson's disease patients have sleep apnea. Parkinson's disease patients have restless leg syndrome. Parkinson's disease patients have, night terrors. And Parkinson's disease patients have something that is called, REM, sleep behavioral disorder, where people are, they're asleep, but they're acting out their dreams and they might injure themselves, injure a spouse. They yell and scream out. And, as smart as one may think that your movement disorder doctor is, that there are only so many finite number of fellowships that one can do. By the time I got out of fellowship, and I had my first job, I was 34 years of age. That's when I got a first job when my husband had already been working for 10 years. So there's only finite number of fellowships I can do. And that's why we need the use of these ancillary, therapists, whether we need a gastroenterologist to manage constipation, or we use the gastroenterologist, when we decide whether we are going to use duopa, which is the levodopa carbidopa intestinal gel pump, to basically, help the patient, that has more of a motor fluctuations. um, and I think that there is, really good use, so sometimes for a urologist, for a sex therapist. I think that intimacy is a big part of life for people. And, with a neurodegenerative disease, that, there are things that people tend to lose. And it's really important. Already, people feel like they have lost something by having a diagnosis. And, I want people to be able to keep their self-esteem, and their sense of self, and the things that, are critical for life. So whatever it is that your problem is, please tell your doctor. Don't be embarrassed. We're only here to help you. You'll be surprised that even now, after 20 years practicing as a movement disorder doctor, especially when I see a Parkinson's disease patient for the Parkinsonism patient for the first time, and I'm getting a detailed history, and I'll say to them, I'm sorry, I don't intend to get personal, but I really need to ask you this question. Is there any sexual dysfunction? And, people will tell you, but if you don't ask, they sometimes don't tell, and that's an untreated symptom. Um, Let me just move this over. Uh, and then, just understanding what each member of the team does. We already know what the neurologist does, diagnosis. They can tell you, of course, they can prognosticate, but not entirely give you a prognosis, don't have a crystal ball, and mostly is the leader of the movement disorder team. Some places have a Parkinson's disease nurse. Susan Imke is one of the best, she's an NP, a very senior person in the community, has been taking care of Parkinson's patients. She may have retired now, but is a very excellent person, very, very knowledgeable. A psychologist, a neuropsychiatrist for management of depression, anxiety, uh, you know, um, post-traumatic stress disorder, any other issues that may have. Speech and language pathologist already talked about. Physical therapist, gait and balance strengthening, occupational therapy, helping with your day-to-day activities of daily living, a sleep specialist, of course, urologist, gastroenterologist, and um, other things such as, sometimes people just tend to lose weight with Parkinson's disease, especially when they have dyskinesias, or people don't eat very much. If they have side effects with Cinemet, and I send them to a dietitian, and it's very useful. sometimes, the pharmacist, I think, is a very important part of our team. They're the ones sometimes will catch some glitches happen. I cannot tell you how many times I'll get a phone call saying, hey, somebody wrote this prescription, but this is not what we had written the last time. What do you want to really give them? And I think it's very helpful. And then, of course, the role of a neurosurgeon when we talk about deep brain stimulation. And this should be a fellowship trained, functional, neurosurgeon that can help with DBS. Um, I put these things here intentionally. I'm not going to go over all the studies that have been cited here for exercise, but the reason I put this in here is to just give you an idea of what all has been studied. I mean, people are looking for all kinds of studies. So whether it is basically just regular PT, whether it is, any form of exercise is good. Aerobic exercise, like the American Heart Association will give you some guidelines about, what does an adult person need to do, how much of exercise you need to do, per day or per week that you can put together. Aerobics is good for cardiac health, but it's good for, lots of other things. Treadmill is very good early in the course of the disease. If you start to have any balance issues, I really don't want people on treadmills, perhaps not even on stairmasters and ellipticals, because we certainly don't want falls. Early stage people who do not have any gait or balance issues and even on treadmill, I wouldn't recommend to run very fast. Run enough to be able to or walk enough to be able to get a sweat. Dance, I highly recommend. I think it's a group activity. It's a lot of fun. I'm a terrible dancer, but I go to a lot of Indian weddings, and that's when I think I get my most dance. And I realize how much I've sweated. It's a great exercise. I don't know whether Mitzi is still doing her dance with Parkinson's. There are some Chinese exercises such as Tai Chi. I think my patients who do Tai Chi really swear by it, that their gait and balance really improved. I think Dr. Mike does Tai Chi basically as well. And, lots of studies, resistance training, doing some bands or doing some weight trainings. I think it is important. And then, these are things, studies that talk about the role of physical therapy, not just for motor functions of Parkinson's disease, but also for non-motor symptoms in Parkinson's disease. And things that they talk about is orthostatic hypotension. They talk about cognitive impairment, sleep, and mood disorders. And these things, exercise releases endorphins. It's very good for mood as well. And then, of course, this is a funny cartoon that I found. While I'm gonna let you focus on that while I get a sip of water. Okay, so this is really important. I'm very worried about falls. Falls are terrible. Somebody that has peripheral neuropathy because of a medication that has had four falls, four really bad falls. One near the Great Wall of China, where I ruptured my deltoid because I was stupid enough to climb the Great Wall looking at my cell phone, which is a terrible thing to do. I still do it. I not learned that lesson. Falls are preventable a lot of times. I tell people in your space, plan your moves as you get up. Look at the length of what you're going to walk, especially if you're somebody that shuffles or that is freezing. If you have grandchildren, take away all the toys. If you have very nice rugs that you got from Turkey or somewhere, you got to put them somewhere where it's not going to be on the ground where you're going to slip on the rug and basically fall. Power cords, night light. Having a night light is good, because if you go to the bathroom at night, you're going to fall otherwise. And that's really, just don't do what I do. Please don't multitask while walking. It's a very terrible habit. I'm gonna try to break it in 2021. And then make your bathtub safer. Like sometimes something with a grip or a grab bar, that would be like really important. Sometimes people have this walking bathtubs, so a lot of people will make changes and renovations in their house so that you do not basically fall. A lot of people even have like bars on the walls. Take your time standing up. As you age, as you're taking higher dose of levodopa, carbidopa, that as you develop autonomic dysfunction such as fall in blood pressure, as you rise up too quickly, you can get lightheaded or dizzy, and that can cause you to fall. So falls are really multifactorial. Um, when people who freeze, I ask them to march like a soldier. Pick up your feet. If you need to walk with a walker or a cane, talk to a physical therapist. Let them decide what assistive device you need. You don't decide that I don't need a walker, and you're falling 7 times a week. It's really really important. Turning, being in narrow spaces is really bad. I don't know how many people fall when they are transferring onto a commode, in a small toilet. I cannot tell you how many people fall when they're in a closet. It's dark, it's not much space there. And it's really important to recognize that freezing of gait can happen, especially in advanced disease, as you're going through these narrow spaces. You've got to plan your moves. You've got to call somebody, your spouse, friend, whoever is there, and avoid falls. Remember, even for men, once you get to be at a certain age, you're just as osteoporotic as a postmenopausal woman, and you are also likely to get hip fractures. So, nobody is invincible, and I really want, fractures are very painful. I cannot tell you how many people developed a fat embolism from a fracture and passed away. So I want people to really avoid, these things. Um, I think nutrition in itself is a big long lecture. There is not a perfect diet that I can recommend, but I like to say a sensible diet. So I think that lean meats are good. I think lots of fruits are good. Of course, if you're diabetic, don't eat some of those sweets that are like pineapples or mangoes or grapes that are very sweet. But vegetables are really good. Vegetables add fiber. Whole grains, beans, those things are good. Like I said, lean meats are good. Of course, there is always a challenge for patients. So most people say that a Mediterranean diet, if you go to Fadis or if you go to I don't know, whatever the Middle Eastern places are in town, or Turkish places in town, that they really have great lean meats, and they have baba ganoush and kibbe and things like that are really. But there is a challenge when you are taking levodopa, carbidopa, and you have to balance your meals, especially if you have to balance protein, because remember that proteins get broken down into these small components that are called amino acids. If you remember your high school biochemistry or college biochemistry, levodopa carbidopa is also made up of aromatic amino acids. When two amino acids come to the gut and in competition, the food is a larger quantity compared to the pidlu, small pill. Guess what? Guess who wins? Food wins. Food gets absorbed, protein gets absorbed, levodopa doesn't get absorbed. You get a delayed on, or you get a no on. And what can happen when you have a delayed on state, delay in developing an on state, or basically being in an off state and freezing. So it's really important to be able to especially balance protein. But like I said, if you really have gastritis, you could take it with some crackers or with applesauce and things like that. And you can always talk to your doctor about um, probiotics or medications that you can take so that you don't have nausea. I don't really recommend, Amy Blasick at University of North Texas can give a whole big lecture about supplements. And, I don't particularly recommend any supplements that are very good, proven evidence. So there is no one diet that is proven best. No evidence that a gluten-free diet is necessary, unless you have gluten sensitivity or celiac disease. More data is needed before a, keto genic diet or keto for Parkinson's disease can be recommended. And a lot of the keto diets basically have high protein because of meat content. So you'll always have to be very careful. Um, so we talked about Mediterranean diets, plant-based food. Olive oil is very good for heart and brain. And there was another diet called the Mind diet. It's also reasonable, but really not not really seen much of it. Um, I think that it's not a bad idea to talk to a nutritionist. You don't want to be very heavy as your disease progresses. And I'm telling this to myself as I tell it to you guys, that it's really important to take care of physical health as well. As the disease advances, you develop more slowness, you develop rigidity, you develop gait and balance problems. The heavier you are, It's terrible when you fall. So, really, it's never too late to take charge of your life. I'll just say in the pandemic, I lost 20 pounds. I still have some weight to lose, but, I work out almost every day, and, it's made me better in a lot of different ways. So I highly, put in a big plug for exercise and put in a big plug for, good nutrition. If required, go see a dietitian. Why do we insist that you go see a a dermatologist at least once a year? There is a higher incidence of skin cancer in Parkinson's disease patients. Especially melanoma is a very common one. The increased risk is not dependent on dopaminergic therapy. It's not the levodopa, it's not the azilect, it's not any of the medications that you are taking that predispose you to developing melanoma. That's a myth. You screen basically, at least once a year. People that have a history, this is what a melanoma looks like. This is, if you see a change, if you see a new lesion, if you see a change in the character of a lesion that you have, you got to talk to your primary care doctor and dermatologist. You know why melanoma is really bad? It's not bad here. It can be taken out here. Melanoma can go here. If it goes to a brain, this is metastatic melanoma, is fatal. It's very highly vascular, and it can basically bleed. A lot of people die of brain hemorrhage because of a melanoma. So take it seriously. Go to see a dermatologist once a year. Get screened. If you have a melanoma that's at this level, it's taken off, no bad consequences. Okay, this is what a metastatic melanoma looks like, and it's very terrible. Um, just I want to answer questions, but let me finish just a couple slides. You know, uh, Going to the hospital is a challenge. Dr. Rao used to say that his biggest goal in life was to keep all his Parkinson's. Dr. Rao was my mentor that I did fellowship with, was to keep all the Parkinson's patients just outside of the hospital. The challenges are, not getting medications on time, finding out if you can bring your, it's not a bad idea to bring your medication. Sometimes they don't have Rytary. Sometimes they don't have Nuplazid in the pharmacy. These are not like regular medications such as, aspirin or Tylenol. Sometimes the pharmacy in a small hospital may not have these things. So bring all your bottles. What the nurses will do, they'll take those bottles, take them to the pharmacy. The pharmacist will look at them, approve, and then allow you or your family member to administer the medicine to you the way you were doing it at home. Okay. There are multiple explanations for why there can be worsening of Parkinson's disease while in the hospital. Certainly, infection, something to be taught about. I cannot tell you, and I feel really bad, how many times a patient with, with psychosis, with hallucinations, with Parkinson's disease that shows in a hospital, gets given something like Risperidol or olanzapine or Haldol even. These are medicines that block the D2 dopamine receptors. Those are the same receptors, D1 and D2, on which dopamine acts. Your endogenous dopamine and your exogenous dopamine, are not working anymore because your receptors are blocked. You become even more Parkinsonian, you become worse, and there can be even more, So there is a list of medications. You can find it on any of the legitimate websites. If you're going to go to the hospital, just print out that list. And, it is not a bad idea that, to look at what are the medications that you are going to give me while I'm in the hospital stay. It's not a bad idea to ask about this, or it is not a bad idea. I don't feel insulted if somebody tells me I have cardiac disease, Dr. Chitnis, and these are some medicines that I would like you to take a look at. Please don't start me on any of those medicines. I think we're being partners. It's very important. I don't want to give a patient a wrong medication. It's disastrous. So we talked about infections and medications, common causes of confusion during hospitalization. Certainly, a patient that's lying down, chest physical therapy is important. Insist on getting a speech. If you are doing speech therapy at home and you're not able to do that, please have your team call a speech therapist. Physical therapist is very important. If you're lying down, you're at risk of blood clots, you're at risk of skin breakdown, you're at risk of urinary infections. We don't want any of that. You have to be your best advocate, and we certainly are, being your advocates. So be aware of what procedures can be done safely, especially with, so I wanted to say, if you have a DBS device, people will call me and say, can I get AMRI of my knee? Or can I get MRI of my back? And now A lot of the companies are making MRI compatible devices, both Medtronic, Boston Scientific, as well as Abbott. But still, I always want people to get an MRI, at my center if I'm taking care of you. The reason is not because UT Southwestern needs to make more money getting MRIs, because we have a protocol in place. Your safety is really paramount. We have a protocol in place. Dr. Yazdani and I work on this, and we make sure that you're shut off, your impedances are checked, that everything's in place. You get the right kind of a magnet for MRI. This is very important. I cannot emphasize how important your safety basically is. And this is like the list of medications, especially the dopamine receptor blockers, crazy. And just look at the list of medicines that are problems, right? And then if you're going to have surgery, and this is probably my last 1 or 2 slides. If you're going to have surgery, I always encourage my patients to tell me about it. I'm having knee replacement. Can you talk, Dr. Chitnis, to my doctor uh, before, not on the day of, not the day before, a week before, even 2 weeks before. These surgeries are planned ahead of times. If you tell me, here's a number for my doctor, call the doctor. When I'm driving back from home, that's when I make these phone calls. I'll call the doctor. I'll say, Dr. Jones, my name is Dr. Chitnis. I'm the movement disorder neurologist for so and so, and I understand that you're planning on doing knee replacement on our mutual patient. How can I help you? Let's talk about anesthesia. Let's talk about what medications you're going to give my patient. Let's talk about whatever it is that you have questions about. If my patient is DBS, how can we help you so that we can turn the DBS device off? What kind of a tools you're going to use. There is something that's called diathermy that is not recommended for patients with DBS. I want to make sure dental surgeries, like, I talk to all kinds of physicians who are going to do surgeries on my patient, because I want to make sure that, my patient does not get into any kind of trouble while they're having, surgery. Got to understand that, really drooling is a big problem. Swallowing difficulty is a big problem. I want to make sure that nobody aspirates. People get intubated. I do not want anybody to aspirate. People who have cognitive dysfunction do not do well with general anesthesia. We do a lot of replacements of DBS batteries. Dr. Lega can do this under local anesthesia. So, I always make sure I'll at least do a screening cognitive test on the patient who's going to go in for, but I already know most of our patients very well. And we'll just say, not going to do general anesthesia, going to do a local anesthesia. One important thing, it's not always available, but the medicine called Parcopa, which is, the oral disintegrating tablet of levodopa, carbidopa, I always give that to a lot of patients who are going to undergo surgery, because the morning of, you may take your blood pressure medicine, but, sometimes, people forget that you got to take levodopa, carbidopa or not. There's always a concern. Can we take it? Can we not take it? Nobody knows. I suggest for people to take, I'll give them an equivalent dose of Parcopa. And, they don't need ice chips, they don't need anything. You put it under tongue, you suck on it. It is easy. If you're in the off period, you've been 12 hours off medication, it is very hard sometimes to intubate because of so much rigidity. So, I just want to protect my patients against any problems that have been, may happen. And so if you've been diagnosed with Parkinson's disease, be an effective partner with your doctor. Make your doctor also accountable to help you with different things. We talked about the multidisciplinary team. I just can't belabor the importance of, exercise. Like we talked about, no, like, Parkinson specific diet or supplements, healthy diet, plenty of water. Again, if you have congestive heart failure, renal failure, you need to, confer with your doctor as to how much water is going to be basically, safe for you. Good sleep, whack myself on the head because I don't do a good job of that. Signing up of clinical trials once COVID is done is very important. Somebody has to contribute to the discovery of new medications. If you don't, how are we going to discover new medications for posterity? Always be, and who knows? I mean, you get the real deal, not the placebo, and you help in the discovery of a new medication. Be a strong advocate for self, be a strong advocate for others with Parkinson's disease. Parkinson's disease is just like somebody having diseases that we don't see. We don't see diabetes, we don't see high cholesterol, we don't see hypertension, right? We don't see a lot of these things, but people have these. So but just because Parkinson's is a movement disorder that is apparent on surface, we have no reason to worry. We're just as good as anybody else. Again, joining a support group, personal preference. I personally like it. I think that you got to come out and meet other people, and it's very helpful. Start planning for a future. It's always a good idea to, like, plan for a future. Anyway, I mean, you start planning for a future once you get your first job, you get married, you have a child. So keep doing that, and keep regularly updating what your requirements are. Also, empower self with the best knowledge available about Parkinson's disease. We're doing this every month, sometimes even twice a month, and our goal is to basically empower you guys with the best knowledge about Parkinson's, the accurate knowledge about Parkinson's, so that you're able to basically really take good care of yourself. And with that, I think I'm going to stop. I went a little ahead than what I wanted to, but I'll definitely answer questions. So let me look over here in the chat and see what people are asking. Why is Rytary so expensive? Anytime a new drug comes in the market, of course, there is technology that goes behind the manufacture of Rytary, because, as you know, it consists of three different kinds of beads. There is an immediate release beads, and then which quickly kicks in, and there are basically control release beads. To develop this technology, to do the clinical trial, it takes a lot of money, and these drugs basically eventually became generic. So the drug companies only have that window of opportunity of the first 10 years or whatever to make all the money, which is millions of dollars that they invested in making these medications. I mean, if insurance can certainly pay for these things, then it would be very helpful. Cinnamon makes me ill. Yes, it makes a lot of people ill. I think if no, I won't be stupid enough to try another medication unless I need it. But I think that it can make you have gastrointestinal irritation. It can make you have nausea and vomiting. But these things can be treated. Like I said, you can take it on an empty stomach. I need you to take it. So take it with crackers, take it with applesauce. Call me. We'll talk about Tigan. That's the best medication that you can take for treatment of nausea with Parkinson's disease. We can pre-medicate. We pre-medicate people that take the apomorphine, subcutaneous injection with Tigan. So talk to us. We definitely have tricks, that help. What if you're allergic to morphine? That's a really good question. I think apomorphine is a little different from morphine. That's a you got me there. I haven't ever come across. I think you're probably still okay because apomorphine is a little different. But I will have to get back to you with that question. Thank you, Sharon. Do you recommend the COVID vaccine? Um, yes, I do. I think that I've talked a lot to infectious disease physicians. I think that there's a lot of faith in the medical community about both the Pfizer vaccine and the Moderna vaccine with a very high degree of efficacy. I think that we really this is what is going to be required to like we say eventually get once everybody develops herd immunity, then I think that we won't be see like it is not like because I've had the vaccine now that of course my ability to get COVID disease will be reduced, or if I do develop something, it will be a very milder form of disease, but I still transmit. So, I still transmit. So it's not like I'm, just because I have the vaccine that I don't transmit to other people. So the only way we can prevent this is, now I will say in all honesty, various people have developed, various thank you for the article on the COVID vaccine. Yes, Movement Aware Society always has a position statement. I will say that people develop various side effects. I had personally, myalgia. I had flu-like symptoms. For the first time, but also for the second time. But I knew I was doing this because I need to develop, I need to develop herd immunity. So I think that it is, really important. Unless there is a specific contraindication, you will have to talk to your primary care doctor. My suggestion is, I don't have any contraindication from a Parkinson standpoint, but you do need to talk to your primary care doctor. Polio is a peripheral disease. So really, Parkinson's disease is a central disease. So there is no relation, because polio basically affects, what we call the anterior horn cells, which are very well where the spinal cord starts. So damage to the neurons by polio would not contribute to Parkinson's disease, which is a central disease. Um, Fiber supplements like Metamucil inhibit levodopa absorption. Um, should not. But if it's taken at the same time that you're taking levodopa, then it's physically present in the gut, and it certainly can. So if you're going to take Metamucil, I would suggest that you take it, early in the morning, or take it in between your doses of levodopa, so that it should not be a problem. Because once you take Metamucil and you're having regularity, then you can absorb Cinemat better. I would not recommend it to take it along with, not simultaneously present at the same time. Does Parkinson's cause clenching of the toes and fingers? That is pulling down and under of toes and curving into the palms of the fingers. Yes, it certainly does. That's called dystonia. This is the curling of the toes and the fingers. This can happen when the Parkinson's medicine wears off, as in wearing off dystonia, but sometimes it can also happen in people who are on, and they can have on with, with dystonia or with dyskinesia. So certainly, that is very much possible. More question and answers here. Does Miralax absorb the absorption of levodopa? It should not. Miralax is basically polyethylene glycol. It essentially dissolves into the into the water or whatever thing that you basically take. But I always recommend people to not take any of these things along with the levodopa, carbidopa. Just take your Miralax, and then basically do your levodopa, carbidopa basically later. Okay, so somebody says, please discuss heritage issues for children when both parents have been diagnosed with PD. Is testing advised? Dat any treatment? I think that's a really good question. I'll say two things for this. It's very interesting that sometimes, we know that insecticides or pesticides can basically cause Parkinson's disease. And, this has been very well reported that it's basically interesting that spouses, that live on a farm and are exposed to a lot of insecticides and pesticides can actually end up developing Parkinson's disease. Now, if there is, if this is genetic or not, I think that what I do is I would basically just send the any child that is curious for genetic counseling. The genetic counselors are very good. They'll draw a genetic tree. They'll basically figure out what your potential risk may be. If your parent has a mutation, let's say that your parent has a autosomal dominant, let's say LARC2 mutation, or has a recessive, like, Parkin mutation. Those are inherent patterns. Somebody that is autosomal dominant, it means that every child has a 50% risk of developing the disease. That doesn't mean that 50% of the children will develop the disease. Each offspring has a 50% chance. If it's dominant, has a 20% chance if it is basically recessive. I think that the genetic counseling, I think, is good. I would not do DAB scan. I think it's, because remember that it could take 20 years. If somebody were to be developing Parkinson's disease, it could take them 20 years to develop Parkinson's disease. Why would I want somebody to live in the fear of the fact that I'm definitely going to develop Parkinson's disease in 20 years? I mean, this is what happens in patients with Huntington's. The highest risk of suicide is in patients with Huntington's disease, because it's such a terrible neurodegenerative disease, as opposed to Parkinson's disease is very, very treatable, very manageable. In terms of treatment. So there isn't a let's say that you're at a high risk of developing Parkinson's disease, but you still wouldn't know. I would just say exercise. Exercise. At some point, my hope is that there will be a way to diagnose people, like, more definitively with a biomarker. Whether it's, we certainly have clinical biomarkers. So, for example, okay, so let me answer this in more detail. If both parents have Parkinson's disease and their family members had Parkinson's disease, and you are a 45-year-old person whose both parents have Parkinson's disease, and for whatever reason, suddenly you develop, REM sleep behavioral disorder, or your sense of smell goes away, or you develop constipation for no reason at all, or you develop depression and nobody in your families had depression. Those are pre-clinical markers, at which point I would be worried about your risk of developing Parkinson's disease. And so, again, there is no treatment, there is no neuroprotective agent, but you would be considered to be higher risk, at which point I think I would see a neurogeneticist and I'd do lots and lots of exercise. I hope that answers this question. Um, I wear a Neupro patch. It says 24 hours. Does it really dose for all 24 hours of the same strength? If I put it on before bedtime and it falls off while I'm in bath in the morning, should I replace it? Or if it falls off in the bath later in the day? So yes, so the way the formulation of the Neupro patch has been generated is that the patch basically, see, you put it on, it has to get to what we call a steady state, and then it pretty much stays constant through most of the duration of the patch, except for at 3 hours before 24 hours, it's pharmacokinetically developed so that it develops a dip. And the reason that it is manufactured like that is so that people do not develop tolerance. Now, it depends on what time. I mean, let's say you put it on at 8 a.m. and you take a shower at 9 a.m. and it falls off. Yes, I would replace it. But basically, let's say that if your time to replace is at 8 a.m. and you get up to go to the bathroom at 6 a.m., decide you're going to have a shower, and it basically comes off, don't worry about it. Just wait for 2 hours and put on a new patch. So you basically just use your common sense, so to say. What does exercise do to the nervous system? How long should he exercise? How many times a week? How intense? Should it be intense enough to study? Lots of different questions. Exercise does lots of different things. Exercise releases endorphins, which can make your mood better. So I always recommend for patients with Parkinson's disease, to basically um, exercise regularly. Even if you have low mood, apathy, I think exercise would be important. There is evidence that suggests that when you exercise, that it can cause the release of nerve growth factors. So these are called BDNF, or brain derived neurotropic factor, or GDNF, which is glial derived neurotropic factor. And these can basically cause sprouting of dopaminergic neurons or preserve these neurons. So I think that exercise being neuroprotective is something that is possible. How long to exercise? I think it is very individual. And it depends on how fit you are. It depends on what kind of comorbid illnesses you are. I think the best person to help you determine, what would be safe for you would be your primary care doctor. I can certainly say, when I examine people, I do a pull test. I say, oh, don't do treadmill, do a stationary bike, go for a walk, those kinds of things. How many times a week? 30 minutes. So I think that the AHA guidelines, I don't know the latest ones, but I remember like the last year was like 30 minutes of aerobic 5 times a week. And then, do some stretching, do some strengthening. Um, Intensity, it depends. I know that some people, know about this bicycle, where they did the exercise and they looked at the frequency and it had to be above a certain frequency, that would be, what would be recommended. But I don't recommend whatever you can tolerate. I think it is good to sweat. Again, don't try to do high intensity training, or don't try to do it. Really depends on what you can tolerate and what is safe for you, what you enjoy and what you can do. So you can work with your Parkinson's doctor. You can basically work with you know you can work basically with your primary care doctor, and do that. I don't know the specific question, who in Canada is researching the use of viruses to cure Parkinson's disease. I do not know who. I know, are you talking about any particular kind of, there's a lot of virus related stuff. I mean, there is lots of gene therapy with viruses, such as lentiviruses and adeno associated viruses. You can deliver pretty much any molecule. You can deliver, they had a gene therapy using viruses with AADC, which was the aromatic amino acid decarboxylase, which helps convert, you know, um, the levodopa into dopamine. Also, they used viruses for delivery of nerve growth factors. So you would have to tell me, what specifically that you are asking, and I might be able to tell you. Canada, the top centers in Canada are really University of Toronto with Tony Lang's group. They do a lot of good research. There is and Ontario has a group with Dr. Zog, Mandar Zog, John Stossel is in Vancouver, and then Ottawa, I think has Janice Miyazaki and Tia Comestre. Those are, some main people there. So if you, were to specifically tell me what is, I'd be happy to get you in touch with those people.
I think we got all of our questions answered. Thank you again so much, Dr. Chitnis, for that excellent information. For those of you who are joining us for the first time and are not getting notifications regarding our events, please send us an email at info@skypassfoundation.org or subscribe on our website at skypassfoundation.org, and you will get alerts regarding our upcoming events. We actually have our next Ask the Doctor on the 16th of next month. We're going to be discussing a very pertinent topic, telehealth in the pandemic and beyond. And we're actually reverting back to our interview style format with Dr. Chitnis interviewing a guest speaker on this topic. So registration for that will open in a few days. So be on the lookout for that. And with that, we will go ahead and wrap it up for tonight. Thank you again for joining. Have a great night, everyone, and we'll see you next time.